Good morning to all. Uh, I'm Dr. Bharathi, Associate Professor from Department of Pathology. I'm going to talk about a topic called chronic leukemias. So before going into the topic proper, we know leukemia is just a malignancy of blood cells, white blood cells. So leukemias can be classified into lymphoid leukemias as well as myeloid leukemias. And again, it can again be classified into acute and chronic leukemias. So today we are going to talk about chronic leukemias. So chronic leukemias, there are two types of chronic leukemias, chronic myeloid leukemia and chronic lymphoid leukemia. So before going into the topic proper, let us discuss about the normal hematopoiesis. So the circulating blood normally contains three main types of mature blood cells. As we all know, they are red blood cells, which is otherwise called as erythrocytes, white blood cells, which is otherwise called as leukocytes, and platelets, which is otherwise called as thrombocytes, as you all know. So the WBCs is again classified into granulocytes and agranulocytes. What are granulocytes? Granulocytes or the WBCs which have granules in it. So what are the WBCs which have granules in it? Like eosinophils, neutrophils and basophils are the WBCs which have dense granules in their cytoplasm. What are agranulocytes? Agranulocytes are the cells which do not have granules in the cytoplasm such as lymphocytes and monocytes. As we all know, the lymphocytes is again divided into B lymphocytes and T lymphocytes. How we are dividing lymphocytes into B and T? Depending on the area of maturation. If it gets matured in the bone marrow, it is called as B lymphocytes. And if the lymphocytes are matured in the thymus, it is called as T lymphocytes. So these are agranulocytes. And again, you have monocytes. Monocytes is again divided into macrophages and dendritic cells. Yes, you want. So the WBCs is divided into granulocytes. The cells which have granules in it are called as granulocytes, and agranulocytes, the cells which do not have granules in the cytoplasm like lymphocytes and monocytes are called as agranulocytes, and which have granules in it like eosinophil, neutrophils and basophils are called as granules. So can you see the morphology of neutrophil, eosinophil and basophil? Neutrophils have lilac colored granules in their cytoplasm. Eosinophils have reddish orange colored granules and basophils have dark blue color granules all over the cytoplasm. And this is monocyte and lymphocytes which do not have granules in the cytoplasm. So first you should know the difference between granulocytes and lymphocytes. Next. The hematopoietic progenitor cells, as we all know, these WBCs, RBCs, and platelets are derived from a common hematopoietic stem cells or progenitor cells. So these hematopoietic stem cells or progenitor cells gives rise to common myeloid progenitor cells and common lymphoid progenitor cells. So you should be clear with this basics. Only then you will be able to understand the rest of your leukemias. Okay, so the common myeloid progenitor cells gives rise to all the other WBCs like neutrophils, monocytes, basophils, and eosinophils, along with the platelets as well as erythrocytes, that is RBCs. And this common lymphoid progenitor cells gives rise to only B and T lymphocytes alone. Okay, are you all thorough with this concept? The hematopoietic progenitor cells. This is the hematopoietic stem cells or progenitor cells, which gives rise to common myeloid progenitor cells and common lymphoid progenitor cells. The common myeloid progenitor cells gives rise to erythrocytes, megakaryocytes, and granulocyte monocyte progenitor cells. Clear? So, this common myeloid progenitor cells gives rise to megakaryoblast, which is a precursor to platelets, which in turn gives rise to promegakaryocyte, megakaryocyte, and then platelets. Till this level, all these cells are seen only in the bone marrow, and platelet comes to the peripheral blood. So, the myeloid progenitor cells gives rise to megakaryocytic lineage, Again, the myeloid progenitor cells gives rise to pro-erythroblast, erythroblast, polychromatic erythrocyte, then RBCs. So the mature RBCs comes to the blood. So this comes under erythroid lineage. So the megakaryocytic lineage, the erythroid lineage, and the granulocyte monocyte progenitor cells gives rise to myeloid lineage. In the myeloid lineage, the precursor is myeloblast, which gives rise to neutrophilic precursor, which gives rise to basophilic precursors, which gives rise to eosinophilic precursor and monocytic precursors. So what are the precursors of eosinophil? Eosinophil has myeloblast, promyelocyte, myelocyte, metamyelocyte, neutrophilic band forms and mature neutrophils. Same way all the other cells have their precursors in the bone marrow. Only the mature cells comes to the blood. You should be very clear with this um, scenario, right? Because these precursor cells will be seen only in the bone marrow. All the other mature cells will be seen in the blood. Okay. So the megakaryocyte, the erythrocyte, and all the granulocytic precursors will be seen in the bone marrow. Only the mature cells will be seen in the blood. Clear? The same way, the common lymphoid progenitor cells gives rise to lymphoblast, prolymphocyte, and which again divides into B and T lymphocytes. So, all of you are clear with this basics? Again, I will repeat. The hematopoietic stem cells or progenitor cells gives rise to common myeloid progenitor and common lymphoid progenitor. So, the common myeloid progenitor gives rise to megakaryocytic series, erythroid series, as well as granulocyte monocyte series. Okay, so all these things gives rise to mature RBCs, mature WBCs except lymphocytes, and mature platelets. Okay, next, the common lymphoid progenitor cells gives rise to lymphocyte. Okay, this topic, this thing you should be very clear. So now let us discuss. This is another diagrammatic representation where there is an hematopoietic stem cell which gives rise to myeloid progenitor cell and lymphoid progenitor cell. The lymphoid progenitor cell gives rise to T lymphocyte, B lymphocyte, and NK cell. This B lymphocyte in turn again gives rise to plasma cells that you all know. Okay. The myeloid progenitor cell gives rise to megakaryocyte, which matures into a mature platelets in the circulating blood. Again, eosinophils, basophils, RBCs, monocyte, and neutrophil. Clear? Now I want all of you to know about the precursor of neutrophil. Okay, precursor of neutrophil. Why you want to know all these things? Because our topic is concerned regarding all the precursors. So these precursors of the neutrophils will be normally seen only in the bone marrow. They won't be seen in the peripheral smear in normal individuals. If all the precursors, including myeloblast, is seen in the peripheral smear, it means that the patient is having leukemia. Simple term. Okay. So, what are the precursors of neutrophils? The neutrophils, this is segmented neutrophils. Then you have band forms, metamyelocyte, myelocyte, promyelocyte, and myeloblast. All these things starts with the blast. If you see blast in the reference here, it is something. That time you have to consider that the patient is having leukemia. So the percentage of blast is also very important. Okay. So myeloblast, promyelocyte, myelocyte, metamyelocyte, band cells, and segmented neutrophils. In normal individuals, you will see only segmented neutrophils in the peripheral sphere. Whereas in a patient with CML, you will see all the cells in the peripheral sphere. All the precursors of neutrophils you will be seen in the peripheral sphere. Okay. So, as I told you earlier, the leukemias can be classified into acute myeloid leukemia and acute lymphoid leukemia. Same way, chronic myeloid leukemia, chronic lymphoid leukemia. So, the myeloid leukemia is composed of myeloid series. The lymphoid leukemia is mainly composed of lymphocytes. So, what is acute and chronic? As you all know, acute is of the duration is, the onset is very insidious. It is soon. Whereas chronic chronic leukemias takes time. So the onset of chronic leukemias is delayed. Okay. So acute leukemia is usually seen in the children, whereas chronic leukemia is usually seen in adults. Okay. So what is leukemia? You should know the difference between leukemia and lymphoma. Leukemia is used for neoplasms presenting with widespread involvement of bone marrow, usually which is represented by the presence of large number of tumor cells in the peripheral sphere, especially the blast. If you see blast cells in the peripheral sphere, you call it as leukemia. When do you call it as lymphoma? Lymphoma is used to describe proliferations arising as a solid mass, discrete tissue mass in the lymph nodes, liver, spleen, and other organs. So now you should know the difference between leukemias and lymphomas. Leukemia is a neoplasm, which arises in the bone marrow, and you can see large number of tumor cells in the peripheral sphere. Whereas lymphoma is used to describe proliferations arising as a discrete mass in organs like bone marrow, liver, spleen, lymph nodes, etc. So both acute and chronic leukemias are further classified according to the prominent cell line involved in the expansion. If prominent cell line is of myeloid series, it is called as myelocytic leukemia. You can add whether it is acute or chronic. If it is acute duration, you have to call it as acute leukemias, acute myelocytic leukemia. If it is of chronic duration and if it is seen in an elderly patients, you can call it as chronic myelocytic leukemia. And if the prominent cell line is of the lymphoid series, it is called as lymphocytic leukemia. So the leukemias, if it is myeloid series, it is called as myelocytic leukemia. If it is from the lymphoid series, you call it as lymphocytic leukemia. Depending upon the onset or the age of the patient, when the leukemia is seen, you can classify it as acute and chronic. Clear? All of you are clear with this? You should be able to differentiate what is leukemia, what is lymphoma. Leukemia, if it is seen in the peripheral blood, the tumor cells are seen in the peripheral blood, it is called as leukemia. Lymphoma, if the tumor cells are seen in a solid organs like lymph nodes, liver, spleen, and other organs, it is called as lymphomas. Clear? So first you should know the difference between the myeloblast and the lymphoblast. Okay. So myeloblast, see this is myeloblast. Myeloblast is a large cell with an abundant cytoplasm and it has a round to oval nucleus and with a lazy chromatin pattern with prominent nucleoli. You can see so many prominent nucleoli. Whereas lymphoblast is a small condensed cell which has very scant cytoplasm and condensed chromatin where you cannot see prominent nucleoli. In myeloblast, sometimes you can see cytoplasmic inclusions which are otherwise called as or rods, So this is a myeloblast and this is a lymphoblast. Myeloblast is a large cell with abundant cytoplasm and which has a round nucleus and round to oval nucleus with prominent nucleoli. Sometimes you can see cytoplasmic inclusions in it which are called as or rods. Whereas lymphoblast is also a cell, a large cells or a condensed cell which has a very scant cytoplasm, condensed chromatin, and you cannot see prominent nucleus. This is the basic difference between myeloblast and lymphoblast that you should know. Now let us move into our topic proper, which is chronic myeloid leukemia. I hope all of you are thorough with the basics, normal hematopoietic system, that is there are from hematopoietic stem cells, which gives rise to myeloid precursors and which gives rise to lymphoid precursors. And the myeloid precursors, you get RBCs, WBCs, platelets, and WBCs, all the WBCs except lymphocyte. From the lymphoid precursor, you get lymphocytes, T lymphocytes and B lymphocytes. Okay. Now, let's move on to our topic number, which is chronic myelogenous leukemia. So, chronic myelogenous leukemia is one of the myeloproliferative neoplasm of pluripotent hematopoietic stem cell which is characterized by overproduction of cells of the myeloid series, which results in marked splenomegaly and leukocytes. So let's go back here. Can you see? This is the hematopoietic stem cells. So chronic myeloid leukemia is a myeloproliferative. There is proliferative disorder where the mutation occurs. The mutation occurs in the hematopoietic stem cells or progenitor cells. That you should be done. Okay. Where is the mutation in CML? Mutation occurs in the hematopoietic stem cells or progenitor cells, which results in marked leukocytosis. What is leukocytosis? Leukocytosis is nothing but increase in the WBC count. Increase in the sense how much? It will be in lakhs. The patient will have 1 lakh, 1.5 lakh WBC count. The patient will present to you with marked splenomegaly. There will be enlargement of the spleen. And the patient will have vasophilia. There will be numerous basophils in the peripheral sphere. So what is the definition of CML? It is a myeloproliferative disorder of pluripotent hematopoietic stem cells, which is characterized by marked leukocytosis, that is increase in the WBC count, marked increase in the WBC count, that is up to lakhs. The patient will be having splenomegaly. The patient will be having vasophilia. Okay, so how do you differentiate this CML from other myeloproliferative neoplasm? What is the key point that you will distinguish? This is CML. This is not other myeloproliferative neoplasm. How will you differentiate? It is distinguished from other myeloproliferative neoplasm by the presence of chimeric fusion of BCR-ABL gene. I will tell you what is BCR-ABL gene means. Okay. As a result of chimeric fusion of BCR-ABL gene, you will get a chromosome which is called as Philadelphia chromosome, So CML is characterized by the presence of Philadelphia chromosome in about 90% of the cases. In about 90% of the cases, what you will see? You will see Philadelphia chromosome. You will confirm CML with karyotyping by the presence of Philadelphia chromosome. Okay. So what is the etiology? What is the main risk factor for chronic myelogenous leukemia? Exposure to ionizing radiation and benzene are the most common risk factor for chronic myelogenous leukemia. Now let us move on to the molecular pathogenesis of chronic myelogenous leukemia. I told you, no, Philadelphia chromosome. So what is Philadelphia chromosome? Philadelphia chromosome is an acquired chromosomal abnormality in all proliferating hematopoietic stem cells. This Philadelphia chromosome, this balanced reciprocal translocation occurs where it occurs in the hematopoietic stem cells. As I told you earlier, CML is the disorder of hematopoietic stem cells. So this mutation or this translocation takes place in the hematopoietic stem cell. So this acquired chromosomal abnormality is seen in all the proliferating hematopoietic stem cell lines such as erythroid, myeloid, monocytic and megakaryocytic precursors. Okay. So there is balanced reciprocal translocation between long arm of chromosome 9 and chromosome 22. That is, there is translocation between chromosome 9 and chromosome 22. So because of the translocation, there is increase in the length of the chromosome 9 and there is shortening of chromosome 22. This shortened chromosome 22 is called as Philadelphia chromosome. I'll show you the picture. Can you all see? This is normal chromosome 9. This is normal chromosome 22. In normal chromosome 9, you have an area which is called as ABL. In normal chromosome 22, you have an area which is called as BCR. This is a gene. BCR is a gene in chromosome 22. ABL is a gene which is present in chromosome 9. Are you all clear with this point? Excuse me. So, BCR is present in chromosome 22 and ABL is present in chromosome 9. Now, there is reciprocal translocation between chromosome 9 and chromosome 22. So the chromosome 9 goes here and chromosome 22, this part, comes here. So there is fusion of this ABL and BCR region in chromosome 22, which results in shortened chromosome 22, which is called as Philadelphia chromosome. I hope all of you are clear with this point. Yes or no? Yes. There is chromosome 9 with a gene called ABL. There is chromosome 22 with a gene which is called as BCR. There is balanced reciprocal translocation between chromosome 9 and chromosome 22. So the ABL part goes to chromosome 22 and there is a cut here and this chromosome comes and attaches to chromosome 9, as a result of which there is lengthened chromosome 9 and shortened chromosome 22. This shortened chromosome 22 with ABL BCR fusion area is called as Philadelphia chromosome. So the BCR ABL fusion gene, ABL proto-oncogene from chromosome 9 joins the BCR on chromosome 22. It produces a new chimeric gene called BCR-ABL, thus converting ABL proto-oncogene into an oncogene. The product of the fusion gene plays a central role in the development of CML. So the product of this oncogene, that is oncoprotein P210, causes cell division and inhibition of apoptosis. Okay. So this fusion gene shortened 22 chromosome, which is called as Philadelphia chromosome, is produces a protein called oncoprotein. It has tyrosine kinase activity. It inhibits apoptosis in all the cells. So there is abnormal, uncontrolled proliferation. That is why it is called as myeloproliferative disorder. Okay, there is excessive proliferation of all the progenitors. Again, you can see this is another diagrammatic representation. There is fusion between BCR and ABL. ABL is present in chromosome 9. BCR is present in chromosome 22. So there is fusion, BCR, ABL fusion gene. And it is BCR, ABL oncoprotein. So this causes growth factor independent cell division. Okay. So what is the most common age group with which it occurs? The most common age group is between 40 to 60 years of age. Males are slightly more affected than females. And the onset is insidious. As I told you, acute leukemia, sudden onset, chronic leukemia, insidious onset. Okay. Symptoms, non-specific symptoms. That is usually the patient will be fatigue, weakness, weight loss, anorexia. Because the patient will have anemia, the patient will have leukocytosis. Because of, you can ask me, there is 1 lakh production of all the blood cells. So the leukocyte count is higher. It is about 1 lakh. Then why the patient is having infections? Because all the immature red cells, all the immature WBCs come into the blood. Where is the mature neutrophil? Okay, because of the proliferation, excessive proliferation, all the excess of all the precursors will come into the blood. So there is no mature neutrophil to fight against the infection. Okay. So the patient will have splenomegaly, which is caused mainly by leukemic infiltration and extramedullary hematopoiesis. Splenomegaly is moderate to severe and is characteristic feature in majority of the patient. And the patient will also present to you with hepatomegaly. Hepatomegaly may be mild or moderate, which is seen in 60 to 70% of the cases. Now, this CML has 3 stages. This CML has 3 stages. One is chronic phase, accelerated phase, and blast phase. What is chronic phase? Chronic phase is otherwise called as stable or indolent phase. Most of these patients are diagnosed in this phase. It lasts for about 2 to 6 years. If it is not treated properly, it can progress gradually to accelerated phase or abruptly to blastic phase. So there are 3 phases: chronic phase, accelerated phase, and blast phase. So laboratory findings. The patient, what are the laboratory findings you will do? First, you will do TBC for the patient, complete blood count. Then you will do peripheral blood investigations, peripheral smear. In CBC, what you will see, the patient's hemoglobin will be markedly less, usually less than 11 gram per deciliter. The patient will have marked leukocytosis, that is, the WBC count will be markedly increased. Markedly increased in the sense the patient's WBC count will be in almost lakhs. And the patient will have immature WBCs in the peripheral smear. On peripheral smear examination, the WBC count is markedly increased. You will see all immature WBCs. You will see marked basophilia and you will see marked eosinophilia. The patient will have thrombocytosis because it is a disorder of myeloid series. So from the myeloid series, you have RBCs coming out, you have WBCs coming except for the lymphocyte, and you have platelets. So all the three cell lines will be affected. So what will you see in the peripheral smear? In the peripheral smear, RBCs will usually be normocytic, normochromic anemia. WBCs, as I've told you, there will be marked leukocytosis and the total leukocyte count usually exceeds about 1 lakh per cubic millimeter. Usually there is shift to left. So I told you all the WBC precursors of immature precursors of WBCs will be seen in the peripheral smear. So all the granulocytes at all stages of development like neutrophils, myelocyte, metamyelocyte, promyelocyte, and an occasional myeloblast, everything can be seen in the peripheral sphere. The predominant cells are neutrophils and myelocytes. In this phase, blasts are usually less than 1% in chronic phase. Okay, less than 10% of the circulating WBCs. And basophilia, the patient will have basophilia, the patient will have eosinophilia, and decreased NAB lab score. What is NAB? Neutrophil alkaline phosphatase score. So the neutrophil alkaline phosphatase score in CML is decreased below 20. And the platelets range from normal to greater. Sometimes the patients will have thrombocytopenia or sometimes the patient will have thrombocytosis. Up to 50% of the patients will have thrombocytosis. Moving on to the bone marrow findings, the cellularity is markedly hypercellular due to myeloid hyperplasia. And there is a reversal of, and the myeloid erythroid ratio, it often exceeds because there is excessive proliferation of the cells of the myeloid series. The patient will have, the myeloid erythroid ratio will be around 20:1. The erythropoiesis is markedly diminished as the disease progresses. And myeloproisis, there is marked hyperplasia. Blast cells usually less than 10%. Basophils, eosinophils, and their precursors are usually found. Megakaryopoiesis, megakaryocytes are either normal or increased. Most of the time, dwarf megakaryocytes can be seen. This is another important finding. Dwarf megakaryocytes can be seen in the bone marrow. And one of the most important MCQ question that will be asked is sea blue histiocytes, which are otherwise called as Gaucher-like cells or pseudo-Gaucher-like cells, which are seen, which is nothing but the histiocytes, that is the macrophages, which engulf all the lipids from the dead and degraded tissue. So, you can see that these histiocytes will, upon staining, they will give sea blue color. Okay, the cytoplasm will be sea blue color. Okay, so this is the bone marrow finding. I repeat, there is marked hypercellular due to myeloid hyperplasia. The myeloid erythroid ratio is often exceeded, that is 20:1. Erythropoiesis will be seen. It is usually decreased erythropoiesis as the disease progresses. In early stage, it will be normal. As the disease progresses, there will be decreased erythropoiesis, as a result of which patient will have anemia. The anemia is usually normocytic, normochromic anemia. The patient will have myelopoiesis. There is marked hyperplasia of all the myeloid series, especially neutrophilic series. Basophilia and eosinophilia will be seen in the peripheral smear, as well as the basophilic and eosinophilic precursors will also be increased in the bone marrow. And megakaryopoiesis is either normal or increased, and you can see dwarf megakaryocytes in the peripheral smear. And you can see sea blue histiocytes in the bone marrow. Dwarf megakaryocytes is not seen in the peripheral smear, sorry, it is seen in the bone marrow. And histiocytes, histiocytes is seen in the bone marrow. Okay. What are the biochemical findings? The serum uric acid is raised, serum LDH is raised, and Philadelphia chromosome. I told you, no, chromosomal analysis is very, very important to demonstrate a patient with the CML. So it is demonstrated either by chromosomal analysis or fluorescent in situ hybridization or PCR based test. Philadelphia chromosome and BCR ABL fusion gene. So this is a peripheral smear picture from a patient of chronic myeloid leukemia. Can you see? Here, all the immature WBCs can be seen. And these are all mature neutrophils, band forms, promyelocytes, myelocytes, metamyelocytes, everything can be seen in the peripheral smear. This is a pictorial representation of the same. You can see basophilia, eosinophilia, and you can see all the mature and maturing forms of neutrophils can be seen in the peripheral smear. All the mature and maturing, that is myeloblast, promyelocyte, metamyelocyte, band forms, and mature neutrophils can be seen in the peripheral smear of a patient with chronic myeloid leukemia. So as I told you earlier, there are three phases. One is the chronic phase, the second one is accelerated phase, the third one is blast crisis. So in accelerated phase, it is more aggressive and lasts for few months. In this condition, as I told you, in chronic phase, it is up to 10% myeloblast. Here, myeloblast is up to 10 to 19% in the blood or bone marrow. There is striking basophilia. The basophil count will be more than 20%. And the patient will have persistent thrombocytopenia or persistent thrombocytosis. Either the patient will have thrombocytopenia or the patient will have thrombocytosis. And there is megakaryocyte proliferation in sheets or clusters, which is in association with fibrosis. And persistent or increasing splenomegaly, which is unresponsive to therapy, can also be seen in the accelerated phase. So this is a peripheral blood picture in accelerated phase of chronic myeloid leukemia showing numerous blasts. The blast percentage is around 10 to 19%, and there will be striking basophilia. So this is a myeloblast. As I told you, myeloblast is a large cell which with an abundant cytoplasm, and the nucleus will be very large with a lazy chromatin, and 2 to 3 prominent nucleoli will be seen. Moving on to the blast phase or blast crisis, the blood picture resembles acute leukemias and it has a poor prognosis. Sometimes it will be confusing whether it is acute or chronic because the blast will be more than 20% in the peripheral smear. And myeloblast in this case does not contain or rods, whereas in acute leukemia myeloblast you will see or rods in it, which is nothing but a cytoplasmic inclusion you can see. Here generally you don't see or rods in the cytoplasm, very rarely you can see. And the patient will have thrombocytopenia and the patient will have bleeding symptoms. So this is a peripheral blood picture of a patient with CML blast crisis where there is more than 20% of the blast in the peripheral smear. Again, I repeat, CML has three phases: chronic phase, accelerated phase, blast phase. In chronic phase, up to 10% of blast will be seen in the peripheral smear. In accelerated phase, 10 to 19% of blast will be seen. And in blast crisis, more than 20% of blast will be seen in the peripheral. So what is the treatment? The treatment of anemia and thrombocytopenia. First, you have to treat anemia of the patient. Next, you have to treat thrombocytopenia by giving platelet transfusions and imatinib, targeted therapy for binding ABL, BCR, fusion protein. This is the first targeted therapy which is discovered in for chronic myeloid leukemia. And it induces this imatinib induces apoptosis in BCR, ABL positive cells and thus eliminates them. The next line of treatment is allogenic bone marrow transplant and chemotherapy. So now having discussed about chronic myeloid leukemia, I have few MCQ questions for you. A peripheral smear with increased neutrophil, basophil, eosinophil and platelet is highly suggestive of what? Yes, it is obviously Chronic myeloid leukemia. Next question. A 60-year-old man complains of night sweats, weight loss, easy fatigability, and discomfort in the left upper abdominal wall. Physical examination reveals splenomegaly. Laboratory study shows leukocytosis. A peripheral blood smear demonstrates mature and maturing granulocytes, myelocytes, basophils, and occasional myeloblasts. The bone marrow is hypercellular and dominated by WBC precursors. Megakaryocytes are numerous and RBC precursors are less prominent. A smear of bone marrow aspirate is shown in the image. Cytogenetic studies disclose a monoclonal population of abnormal cells with translocation 922. What is your appropriate diagnosis? All of you try to answer this. Yes, the answer is chronic myelogenous leukemia. So this is the blood picture you can see, where you can see neutrophils, band forms, basophils, myelocytes, promyelocytes, etc. So this is the case of chronic myeloid leukemia. So which oncogene is located at translocation 922 chromosomal breakpoint? The patient which is described previously, it is ABL gene. Okay. Next, we're moving on to another topic which is very small, which is called as chronic lymphocytic leukemia or small lymphocytic leukemia. It is a tumor composed of monomorphic small B lymphocytes in the peripheral blood, bone marrow, and lymphoid organs. These are the same entity with different presentations, and CLL, SLL tumor cells express CD5 and CD23. The most common cytogenic abnormalities in this case are common mutations or deletions of 13q, 11q. The most common age group is between 50 to 60 years of age. It is more common in male than in female. The patient usually presents with non-specific symptoms like fatigue, loss of weight, and anorexia. Generalized lymphadenopathy will be seen. The hemoglobin of the patient is usually decreased between 13 gram per deciliter. The total leukocyte count is increased, and RBCs are usually normocytic normochromic, and WBCs shows lymphocytosis and constitutes more than 50% of the white cells. And lymphocytes are usually of mature type with small scant cytoplasm, round nuclei with clumped and closed chromatin, and smudge cells are present, and platelets are usually normal, and it may be decreased later. This is the peripheral smear picture in a patient with CML, where you can see smudge cells. This is the smudge cells, and the peripheral smear constitutes mostly of lymphocytes. The most common immunophenotype in this case is CD5 and CD23. The tumor cells express pan B cell markers like CD19 and CD20. So these are my references. Thank you.